Okay, good morning, everybody. I believe everybody's slowly coming into the room. We are very grateful for people attending our symposium today, and we're really looking forward to sharing some of our results that we have been compiling. To start with, I want to just talk about the high-level issue that we're going to be discussing today. Obviously, there's been a lot of coverage about the mental health and addictions, the potential mental health and addictions consequences of this pandemic. It's as much a social phenomenon as an infectious disease one, and there are many risk factors that we know contribute to the development of mental illnesses and addictions, like social isolation, financial strain. And the one thing that we want you to think about as we go through this presentation is to think about how quickly public health was able to stand up pretty effective measurements for tracking the pandemic. We know how many people are tested each day. We know the case counts. We know the ICU hospitalization rates. We know the hospitalization rates. We know how many people are infected in long-term care. And then think about what we know about the mental health consequences. And that inability to track the mental health burden and the mental health system's capacity to respond to that burden predated the pandemic. And we want to make the case that we have some capacity to measure, which we're going to show you, but we really need to be doing a better job. We have four presentations today, followed by a brief question period. I'm going to be giving you a high-level overview of the acute care sector. Natasha Saunders, Dr. Natasha Saunders and Dr. Alene Toulany are going to be giving you an overview of their work looking at the massive shift of virtual mental health care in children and adolescents as a result of the pandemic. Dr. Simone Vigod is going to be presenting some really innovative and interesting work on a particularly important patient population, which is the postpartum population, and showing what she's finding there. She's an international expert in that area. And my Ontario Mental Health and Addiction Center of Excellence colleague, Ryan Monte, is going to be presenting some of the work that he and others have been doing within the Center of Excellence to stand up very quickly and in a responsive way some measurements to help us understand what's happening in the community care sector, and a little bit about what we're doing to meet the needs of mental health and addictions needs of healthcare workers. Very briefly, excuse me, I just want to tell you a little bit. So if you're here, I'm assuming you know about ICES. It's an Ontario-based Ministry of Health funded research institute that uses the health administrative data that the three of us are going to be using to show you some of our results. But our mental health and addictions program is increasingly working in very close collaboration with the Mental Health and Addiction Center of Excellence, which is a relatively new, we're a year-old agency within Ontario Health, which, I mean, you can read the slide, but really we have a mandate to provide oversight and implementation expertise to essentially help to create systems of mental health and addictions care where none exist. And we do this by using a programmatic approach. For anybody who's familiar with the cancer care system or the renal network, and increasingly the cardiac care system, this will be familiar, but it's relatively new and unfamiliar to the mental health sector. I'm not going to read through the various attributes of the ways we are thinking about doing our work, but this is the way we are thinking about approaching how to be more systematic about the delivery of mental health services and to monitor outcomes, all in the service of creating learning health systems that have led to such provincial excellence in the delivery of cancer care, renal care, and other areas of the healthcare sector. So I'm going to switch now and show you the work that our team has done to track the acute care sector. So before we start, excuse me, I just want to highlight that the data picture for the mental health and addictions consequences of the COVID-19 pandemic are quite confusing. So on the one hand, there has been quite a lot of media attention to what are essentially polling data. And there have been, and here are a couple of highlights. There have been numerous articles in the Toronto Star, in other media outlets, really using polling data, which essentially use survey methods to measure levels of distress, and then to extrapolate from these sort of measures of distress the mental health consequences. And these, for the most part, the vast majority of these are communicating an unbelievable mental health and addictions, mostly mental health and distress consequence of the pandemic. On the other hand, we have just last week, we had data out of the West. Here's Alberta in this article from the CDC that used suicide data from both Saskatchewan and Alberta, is showing that in contrast to the increased mental health burden tracking that is being tracked by the polling data, that suicide deaths are down. And in the same time, a couple of weeks ago, there was a Statistics Canada study that provided some controversy by suggesting that for the majority of children and adolescents do not seem to be too burdened from a mental health and addictions perspective by the pandemic. And this is a very confusing picture for the public to understand, and it's an equally confusing picture for policymakers to understand, because I mean, if you think about what all of this means, it's very hard to know how to respond when there are such divergent messages created by such divergent methods and metrics tracking onto mental health and addictions. And it's a very different story than, say, how we interpret the trends related to the COVID-19 cases in particular that I talked about at the beginning, where we know exactly what the two-week lag is and we can predict how things are going to go. It's very difficult to know what to do in response to what we all believe to be mental health and addictions consequences of the pandemic. Finally, we have some emerging data from the US, which looks similar to the kind of data we'll be showing you today. Here, I'm showing you a very recent article published in JAMA Psychiatry that uses emergency department data. And essentially what you can see is, in the blue line, all mental health and addictions related emergency department visits. You see a very rapid drop at the time of the pandemic and a return to baseline. And that's really what they're seeing in the US. So what are we seeing in Ontario? Well, for hospitalizations, we have data to the end of June of 2020. And we are seeing, even though it's truncated compared to what I just showed you from the US, we're seeing a similar picture that, generally speaking, that there was a completely understandable drop in mental health and addictions related hospitalizations immediately after the pandemic. And then it looks like it's, as of June, climbing back to near pre-pandemic levels. And when we look at age-specific categories, these three groups here are what we call the transitional age youth. The green is 14 to 17, the purple is 18 to 21, the blue is 22 to 24. And generally speaking, you can see that as of June, the rates of hospitalizations are climbing back to pre-pandemic, but not quite there. And this was a population of concern for our group previously, because we were tracking remarkable increases in mental health and addictions related emergency department visits in this transitional age youth category between 2009 and 2017, where rates doubled in that period of time. So this is a population that we are increasingly keeping an eye on from a health administrative data perspective. The emergency department visits story is similar. Here we are tracking to the end of August instead of the end of June. And you can see that the curve is very similar. You have a drop after the pandemic, and then you have a return to pre-pandemic levels by the end of August. And the age specific category looks a little bit the same, although there's a closer return to pre-pandemic levels in the 18 to 21 and 22 to 24 age categories. The 14 to 17-year-olds by the end of August had not returned to pre-pandemic levels. We also were interested in emergency department visits for deliberate self-harm. And for those of you, this would be what we would be measuring to track suicide attempts. And I'm going to take a little bit of time going through this slide. On the top, we have the overall. So this is the emergency department visits for deliberate self-harm. And again, you can see a kind of a little decline pre-pandemic, pretty dramatic dip at the time of the pandemic, and then a return to near pre-pandemic levels. We were very interested in any differences in severity of presentation pre versus post-pandemic. The blue line is the proportion of the emergency department visits for deliberate self-harm that resulted in hospitalization. And here you can see that there's been a very flat line in terms of likelihood to be admitted after the pandemic dip. It has not had a bounce back to pre-pandemic levels after the pandemic. The green line is even a more, I would consider a rarer but more objective measure of severity. This measures the proportion of emergency department visits for suicide attempts that either the individual tragically died in the emergency department visit, or was transferred to the intensive care unit, which is a real marker of severity. And here again, you see a drop post-pandemic, and if death during the emergency department visit or transfer to ICU is an objective measure of severity, which we believe it is, you see that the rate remains low post-pandemic. So this suggests to us that while the suicide rates are returning to baseline, the lethality or the severity of them seems to have dropped. So high-level summary for me is that there's a completely understandable sharp drop in April, followed by mostly a return to near pre-pandemic levels. In some areas for transition age youth, there has not been a return to pre-pandemic levels in all indicators. And for the self-harm, deliberate self-harm emergency department visits, it suggests that the lethality of those visits has decreased somewhat by the time post-pandemic. I'm going to stop sharing my screen and transfer over to my colleagues, Dr. Natasha Saunders and Dr. Alene Toulany.
Can you see my screen?
Yes, we can.
Okay, excellent. Thanks, Paul, for that. So I'm going to shift a little bit now to speak about some work that we've been doing on virtual mental health care delivery through the pandemic, specifically as it relates to children and adolescents. And this work is being led by me and my colleague, Dr. Alene Toulany, who will be speaking to some of the later slides. So as you well know, there has been an unprecedented transformation in healthcare delivery following the World Health Organization declaration of the COVID-19 pandemic on March 11th. And there's been a rapid adoption and restructuring of virtual care by healthcare providers and organizations, made possible by virtual healthcare platforms and digital health innovations and virtual care reimbursement models. So in Ontario specifically, on March 14th, the Ontario Health Insurance Plan changed the schedule of benefits to allow for virtual care billing for physicians in Ontario. Mental health care specifically is well suited for virtual care, especially for children and youth who may be accustomed to technology, but also it often doesn't require a physical exam the way some other health conditions do. Studies on the effectiveness of telepsychiatry demonstrate equivalent outcomes across a diverse mental health conditions in terms of their patient satisfaction, adherence to treatment, and symptom reduction. But the uptake of virtual care among children and youth with continuous or new mental health care needs during the COVID pandemic is not well established. So for this project, we were looking at the COVID pandemic as a stimulus for rapid system transformation to virtual care. We wanted to understand the extent of the shift to virtual care. We also wanted to understand how virtual care may have widened health inequities. So for refugee populations or immigrant populations, those living in low-income neighborhoods. And then we also wanted to understand how virtual care played out in terms of specific mental health conditions. So it may not be a one-size-fits-all, and it may be that virtual care is suitable for some health conditions, but not others. So this was a population-based repeated cross-sectional study of children and adolescents, so ages 3 to 17 years in Ontario using data available at ICES. And we looked back from January 2017 until the end of September of 2020. So there are about 2.5 million children and adolescents living in Ontario during this time period. But before I go through some of our results, what I do want to say is that these data represent physician and hospital-based utilization. So children have to have a health system encounter using their OHIP card. And it also only represents the first 6 to 7 months following the onset of the pandemic. And this is important because it does not show the need or levels of distress, which we have heard about through survey data. It does not show all the heterogeneity across diseases, so that we are using OHIP billing codes, and this does not get at some of the clinical disease groupings quite as well as some of the clinical data that other groups have. And importantly, it doesn't get at community mental health care delivery provided by community mental health agencies, which provides a substantial proportion of mental health care for children and adolescents. And finally, it does not go over utilization, or it does not describe utilization through the second wave of the pandemic. So for children and youth, this is really important because, March, there was the big spike, and then through the summer, things petered out. And as they entered school, there may have been shifts in their social isolation or their levels of distress, but we don't know what has happened through that second wave. So this slide shows you overall outpatient mental health care delivery for children aged 3 to 17 through the pandemic. The first thing what I'd like to show is that this is in-person and overall visits that actually overlap each other because there wasn't a lot of virtual care pre-pandemic. And what you can see here is there's a huge seasonal variation in mental health care delivery for children. So the summer months, the healthcare utilization drops, and then it goes up through the fall and the winter, and then drops again through the summer. And what you see here is the pandemic hit, and there was an 80% drop in in-person visits, which is not unexpected. Overall, there was a 5.4% drop in visits overall. So children and youth, despite the reports of increased distress and increased need, were not actually using physician-based ambulatory mental health care as much as pre-pandemic. And what we saw is that on average, post the onset of the pandemic, there was a 79% of visits were done virtually. Most of this, right after the onset of the pandemic, not surprisingly, this was about 90%, and more recently it's been about 70%. So through September, it's been around 70%. So although we have an increase in virtual visits, it hasn't been quite as sustained as one might expect after the first big bump in COVID rates. To contextualize this overlaps a little bit with Dr. Kurdyak's slides that he presented earlier, but this is the emergency department visits in blue and the hospitalizations in yellow for children and youth specifically, so 13 to 17-year-olds. And again, you can see this seasonal variation in emergency department visits and hospitalizations. This dashed blue line represents the average over time. And as Paul Kurdyak had alluded to, there was this sharp drop in emergency room visits of almost 40%, and almost a third of hospitalizations dropped. And we see that it increased, but certainly has not returned to pre-pandemic levels. So that's to give context of what's happening. It's not that all of these kids who were not being seen in the outpatient setting are now showing up in the emergency department or being hospitalized. That doesn't seem to be the case, but that across all of these sectors, the rates are lower. When we look at this by disease grouping, so in outpatient billing codes, we don't have fantastic clinical groupings, but we can bucket patients into broad categories. So this dark blue line represents the other group, which are children often with autism or attention deficit hyperactivity disorder or other behavioral disorders of childhood. And what you can see, again, the seasonal variation that occurs in outpatient care delivery, but there was about a 7% drop overall in visits. And this dashed line here post-pandemic in the dark blue shows that almost all visits were virtual initially, and then the virtual visits dropped off. But on average post-pandemic, this dark blue line is about 77% virtual visits. When we look to mood and anxiety disorders, which is this lighter blue line, again, we see that there actually wasn't much of a change overall in the post-pandemic onset period, and a 0.1% drop overall. And again, there was this tapering off of virtual visits, so that 82% or almost 83% of visits were done virtually in the first 6 months following the pandemic. Social visits or visits for social reasons. So this can include parent-child problems, educational problems, marital discord that a child's family may go see their healthcare provider about. We saw that there was almost a 20% drop overall in visits, and about 70% of these visits were done virtually. And then for psychotic disorders, which makes up the absolute number, so the total number is actually relatively small compared to all other health conditions, but we saw a little bit of a bump, so a 7.5% increase in overall outpatient visits for this, and about 82% were virtual visits. So this sort of displays what's happening by large disease groupings. I'm going to shift to Dr. Toulany now.
Thanks, Natasha. So on this slide, we have mental health outpatient visits by sex. And to help orient you, females are represented by the dark blue line and males by the lighter blue. Virtual care is shown in the dashed lines. So when you look at overall mental health visits, which includes both in-person and virtual care, for males, they decreased by 10.4% following the pandemic, whereas for females, they were relatively unchanged with a small increase of 1.2% overall. And when you look at the percent of virtual visits, they were similar at about 79% for both females and males. So here you can see mental health outpatient visits by age. So the youngest age group, representing ages 3 to 12, are in the dark blue line, and teenagers ages 13 to 17 are in the lighter blue line. So when you look at the teenagers specifically, we see that there has been a 2.5% decrease in overall mental health visits, 80% of which have been virtual. The drop, however, for younger children has been a bit greater at 7.8% overall, and 78% of these visits have been virtual. This slide shows mental health outpatient visits by material deprivation, where quintile 1 represents the least deprived and quintile 5 the most deprived. Now, there's a lot going on this slide, and I'd like to first focus your attention on the dark blue line, which represents the least deprived. You can see that it's the only group for which there has not been a decrease in mental health outpatient visits following the pandemic. Rates actually increased very slightly by 0.2% overall. And the uptake of virtual care in this group is also the highest at about 80.9%. So as we move from the least to the most deprived groups, the overall rate of mental health visits decreases following the onset of the pandemic. And we see the greatest drop among the least deprived, represented on this graph by the turquoise line. So there was a 12.4% drop overall. And similarly, as you move from the least to the most deprived, the uptake of virtual care decreases. So among the least deprived, the percent of virtual visits was approximately 75.9%. So this slide shows mental health outpatient visits by dwelling density. So quintile 1 represents the least marginalized, quintile 5 the most marginalized or having the greatest dwelling density. So you can see that those living in the greatest dwelling density, represented by the turquoise, have the lowest rate of mental health visits both before and after the onset of the pandemic. However, when you look at the percent of virtual visits, it is similar to other groups following the pandemic at about 79%. And those living in the lowest dwelling density, shown in the dark blue, had the greatest drop in mental health visits at about 9%. Finally, this slide shows mental health outpatient visits by immigrant status. Non-immigrants are represented by the mustard yellow line, immigrants are in dark blue, and refugees in lighter blue. So if we look specifically at the immigrant group, we see a 6.3% increase in the rate of mental health visits overall following the pandemic, 80.5% of which were virtual. Refugees had the greatest decline in mental health visits overall, with a 12.8% drop. They also had the lowest uptake of virtual care, with 68.5% of visits being virtual. So to summarize, our key findings are that ambulatory visits for mental health care have remained largely unchanged following the onset of the pandemic. However, there has been a drop in acute mental health care utilization in the first 6 months of the pandemic for children and adolescents. We do see differences in ambulatory care by age and sex, with mental health visits declining more for males and the youngest children. And as Natasha has shown us, there's been a major transformation in care delivery, with 80% of mental health visits shifting to virtual care. However, this has not been sustained throughout the pandemic. We see that virtual care is most often used among those with mood, substance, and psychotic disorders. And we are seeing inequities in virtual care uptake, specifically among those with high material deprivation and those with refugee status. So our data tell us what's happening in mental health care utilization early in the pandemic, but it's important to recognize that the mental health needs of children and adolescents in Ontario may not equate to service utilization. And the differences among disease groupings right now remains largely unknown, as is the effectiveness of virtual care delivery by disease groupings. So our group wants to better understand what is happening among children and adolescents who are new to the mental health care system versus those with continuing care needs, especially those who may have dropped out of care following the onset of the pandemic. So we're going to be working to answer some of these questions in the next few weeks. And lastly, and I think the most important question is, how can we use our data? How can our data be used to better inform and direct strategies to potentially reduce some of the inequities that we're seeing that are worsening in the pandemic? So our project is supported by funding from the Ontario Ministry of Health and CIHR, and this work would not have been possible without our incredible team listed here in alphabetical order. So you'll see some amazing scientists, clinicians, policymakers, and leaders in the child and youth mental health field in Ontario and across Canada. So thank you to everyone who has supported this work.
Thank you, Natasha and Alene. I just wanted to, while Simone is pulling up her slides, I just want to do a couple of housekeeping questions, which is, first, I forgot to mention it. We are showing you data that has not been published. So we respectfully ask that you not take screenshots and post them because we want to have the opportunity to have this vetted through peer review. Alene and Tasha, there's one question from Aaron Anderson. How do you measure deprivation? Do you want to take that on?
Sure. So we use the Ontario Marginalization Index, which has 4 different pillars, so to speak, or 4 different dimensions. And within that, there is material deprivation. So it looks at census-based measures of, neighborhood level income. I'm trying to remember off the top of my head all the components, but housing that is in need of repairs, a number of social and economic measures of deprivation, and it's used quite widely. So it's the Ontario Marginalization Index, and it's a neighborhood level measure, not an individual level.
And one more question, maybe, because we're a little bit ahead of schedule. This is from R. O'Toole. I apologize, I don't know the full name. Do you think once the data has been updated for a complete year of pandemic and ongoing waves, will the outcomes change to reflect an increased need and usage of healthcare needs?
That's also a really good question. So as we mentioned earlier, that this really only reflects the first wave, and we don't know what is happening in the second wave or the long-term effects. And for children in particular, who have had long periods of time out of school at a time of critical development of their social and developmental needs, it is possible that we may see increases down the road, but we don't know yet. The data will tell us down the road, but right now I don't think we can say. But certainly it is possible that numbers will increase in the months to come.
Thank you. We'll keep track of the other questions. I want to move on to Dr. Simone Vigod's presentation now. So thanks.
Thank you very much, Paul. My name is Simone Vigod. I'm a psychiatrist at Women's College Hospital, and I'm a scientist at ICES. And my main area of interest is in women's mental health. And so I'm going to present some data today that reflect what you've probably, we just moved through the acute care sector for mental health, thinking about children and youth. And now really we're moving into, now we're moving into the postpartum period in mothers. And some of you who have heard me in the past may have heard me say, happy parents, happy children. So as we're thinking about the impact on children and youth, I think we do also have to consider the entire family. I'd like to start by acknowledging the team who worked on the data component. It's quite a large team. Dr. Hilary Brown, Lucy Barker, Nisha Hussein Shamsi, Elise Wright, Cindy Lee Dennis, Sophie Gregoriadis are close trainees and colleagues of mine who work in the pregnancy and postpartum mental health space. Angie Huang, Kinhua Feng at ICS really focused in hard on making sure that we had the right way to capture the data that we can from the provincial level data. Peter Gosdiera helped us with our maps, which you will see about service use in different places in the province. Daniel Corsi and Mark Walker work out of University of Ottawa and CHEO, and they're involved with BORN, the Better Outcomes Registry Network, which is a clinical maternity registry, which we're not presenting data about today, but we're working closely with them in order to contextualize. And Rahim Monedin is a statistician who helped us understand how we could determine whether the service use that we're seeing is different from what we might have expected if the pandemic had not occurred. And here are my disclosures. So I thought I would contextualize a little bit to remind the audience that the postpartum period is a high-risk time both for new mental health issues to develop and also for people who have had pre-existing mental health issues to have recurrence of their mental health issues. Most of the research in this area is in women, although there is some in men and in trans individuals. But from a population perspective, we're talking about up to 1 in 5 postpartum women. So if you think this out to Canada, you're talking about 400,000 births in Canada each year. 20% of those people struggling with their mental illness after birth means about 80,000 mothers every single year across the country. I also remind people when I give these presentations that postpartum mental illness does not mean only postpartum depressive illness or postpartum depression, although sometimes postpartum depression is taken to mean postpartum any mental health issue. But we're also talking about anxiety, obsessive compulsive disorder, post-traumatic stress disorder, alcohol and substance use disorders, as well as more serious mental illnesses such as bipolar disorder and schizophrenia. And mental illness that occurs around the time in pregnancy results in substantial suffering for the mother, difficulty functioning, and sometimes the impaired interactions between a mother and her infant can be linked to problems with development for children across the lifespan. The other issue is that these conditions do not magically disappear or magically get better when a woman comes out of the postpartum period, or let's say at about a year postpartum. And in fact, if not treated well, the conditions can be chronic, they can be recurrent. And so what starts to happen is that we have what are called intergenerational impacts of mental illness that go between mothers and children, and then their children and families. So this is a very large population affected with reverberations that can go in many directions. And I think that's why I was so grateful that this topic was put in today, because we're really thinking about the beginning and ways to break that cycle. I don't have to tell this group that we have for close to a year now been living in a pandemic. Originally, March 11th was the date that the pandemic was declared in 2020. As you heard already, the containment efforts have had quite a mental health toll, at least in survey data where people are reporting psychological distress. Specifically in the postpartum period, some individuals' brains appear to be sensitive to the hormones shifts that occur with childbirth, increasing risk for mental health issues. And then there are all the psychological and social issues in the transition to parenthood, sleep deprivation, role identity changes, conflict with partners. But the main issue here is that the COVID-19 pandemic and its containment efforts have created anxiety around infection, but also substantially increased social isolation. And social support is probably one of the strongest protective factors for postpartum mental illness. And when social support is not available is when we see higher rates of new onset and recurrent illness. And so in many jurisdictions, people have not been able to have support from their broader family, from their broader friends. And we're also seeing reductions in some of the public health support services that are important for maintaining postpartum mental health. Limits to visiting public health nursing to more essential cases. Same thing with lactation clinics, and much of the postpartum support group community, while much of that has moved online, there has been a decrease, especially early on in the early months of the pandemic. So we do have data from prior pandemics suggesting that postpartum women may be disproportionately vulnerable to mental health effects. In the H1N1 pandemic, there was data out of Japan that suggested this was the case. Early in the COVID-19 pandemic, there was some data coming from China suggesting women were disproportionately affected compared to men, which may have had to do with their status as caregivers and healthcare workers. Out of the University of Calgary in March-April 2020, there was a Canada-wide survey, fairly large sample size, of pregnant women showing that about 50% were experiencing significant psychological distress. So we're reporting high levels of psychological distress. More recently, CAMH does a CAMH monitor where they look at alcohol and substance use and reported that mothers of young children were reporting increased alcohol utilization during the pandemic. And you may have seen, I have seen stories in the media of new mothers struggling during the pandemic for the reasons that we have described. But the thing is, we don't know, as Dr. Kurdyak was saying initially, we don't really know how some of the survey data is translating into whether people have a need for service or whether people are using services. So because we have this close to real-time healthcare data in Ontario, we do have the opportunity to look at women who've delivered a baby, all women between 0 and 12 months postpartum, which is a standard time frame that's looked at for postpartum, to think about and look at whether visit rates for postpartum mental health issues in the early months of the pandemic, I'm going to present you data from March, April, May, and June 2020, differed from what we might have expected based on pre-COVID patterns. And we used about 4 years of data prior to the pandemic to make our comparisons. So first, to situate, pre-pandemic, we had about 140,000 women eligible each month. So basically there are about 140,000 births in Ontario every month. And each month, about 3.1% of these women had at least one visit for mental illness. So that's about 1 in 20. It's actually not a very small number. Most of these visits were to primary care physicians, but you can see over 30% were to psychiatrists. Very, very few pre-pandemic visits were conducted virtually, and you saw this with the child and youth data, so less than 5% there. Most commonly, the diagnoses were anxiety disorders, followed by depression, alcohol and substance use disorders, bipolar and psychotic disorders, and anxiety disorders here would include also related issues such as post-traumatic stress disorder, obsessive compulsive disorder, and these are physician visits. During the pandemic, about the same number of women each month, slightly higher percentage of women had at least a visit in every month. Similar pattern, most of the visits in primary care. Virtual, though, you can see in March, where we had the state of emergency declared March 17th, halfway through the pandemic, almost 50% of visits in March as a whole were virtual. And then April, May, June, you can see we're up in the 80% range of visits for postpartum women were done virtually, which is quite high. And again, a similar breakdown of the types of diagnoses that we're seeing in these visits. Mainly the catch-all around anxiety. And it's interesting, we talk a lot about postpartum depression as a catchphrase. It's become more and more clear that postpartum anxiety is probably a much more common condition. So here is the first graph that I'm going to show you, and I'm going to orient you to see that prior to the green line is our baseline data for the 4 years. And all of the blue dots represent the rate of visits per 1,000 women at each individual month. And what you can see looking at everything before the green line is that while there's some variability, you can see how the numbers drop dramatically in December, which is probably reflective of simply people not being seen in the healthcare system all that much in December. But you can see that the pattern over time is pretty consistent. Then what we have, the green line represents March. And the black dot that's right on the green line represents the observed visit rate in March. The red dotted lines and that blue line are the models. So the blue line that goes up and down is what is the model that we would be expecting. And then the red dashes are like, that's our room for error in the modeling of what we might expect. And so what you can see here is that even in March, even though the pandemic only happened halfway through the month, we were already seeing higher numbers of visits than would be expected in March. And then you can see the subsequent 3 dots in April, May, and June that we are seeing a significantly greater observed number of visits than we would have expected prior to the pandemic. And what I would note is that this is in contrast to what you saw with the acute care utilization that Paul started with. And it's also in a bit of contrast to what you saw with the slight reductions in service use with the children and youth. So I think this does tell us, partly helps us understand why some of the data, as Paul was saying, are a little bit confusing, because I think what's clear is that different things may be going on in different populations and for different reasons. This next graph shows you on the left the primary care provider visits, and not surprisingly, this looks very similar to the graph before because most of the visits were in primary care. What I think is very interesting is that if you look at the graph on the right, the psychiatrist visits, what you see is that in March, There was no elevation in visits. Then in April, May, June, there were. This probably makes sense in our system where first, these women are going to be first seeing their primary care providers for mental health issues. And then for those women who are not, who the primary care providers are not sufficiently able to treat or manage or advise, those referrals then would go to psychiatry. And we'll start to see the elevated visit rates starting in April with the psychiatrist visits. What I'm showing you here are the diagnostic groupings. And, you know, not surprisingly, and probably in line with the survey data, right away you can see at the top, I made a big, thick red arrow because those are what we are seeing are higher rates of visits, mainly driven by anxiety and anxiety disorders. And these are physicians are marking down a diagnosis of an anxiety disorder. This is what you're seeing here. What's also interesting in the slightly less thick red arrows are that for depressive disorders, so that would be major depression and related disorders, as well as for alcohol and substance use disorders, while we did not see increased rates compared to what's expected in March, because what you can see is that the black dots with the lines going through are right on the gray line, which essentially represents no difference from expected. After that, April, May, June, for both depressive disorders and alcohol and substance use disorders, we are seeing elevated rates of visits. We did not see that for bipolar disorders or psychotic disorders. And I think it's probably reassuring that we, at least in those groups, didn't see less access and less visits. And then the bottom is just another category that I cut off so that you could see the graph more clearly. We also looked, and this was very helpful, we also took a look at some particular characteristics of these women to see if there were specific populations where there was more service use. I put a star at the women who were in the early postpartum, because what you can see about these women is that while the expected rate of care for these women is actually a little bit, tiny bit lower than the women, you know, later in the postpartum, the difference between the actual rate that we observed and what we expected to see were much, much greater. I don't know if you can see my pointer, but were much, much greater for women in that early postpartum phase than for women later, although the women who were later in the postpartum also had elevated rates. We didn't see a difference between if women were primiparous, meaning that this was their first baby, or multiparous, meaning that this was not their first baby, which is also interesting because we do tend to think that women who are having their first baby tend to have more difficulty from a mental health perspective. But I think one thing we know about the pandemic with women having multiple children at home, not in daycare, et cetera, I wonder if part of what we're seeing here is the stress on that population as well. The other thing that we did was we had access to people's postal codes, which means that we can look at what their neighborhood level income is. The thing I wanted to highlight here was that quintile 1 is the 20% of people who are in the lowest income neighborhoods. This group did not see the same kind of elevations in visit rates as some of the higher income groups. And the question in my mind is, why is this the case? These are the individuals who we might expect to be most stressed, to need care most. I worry that what we're seeing here is an access issue, that we're seeing people who are essential workers who've had to go back to work, maybe people who, you saw how much virtual care there was, maybe people who don't have access to virtual care and are facing problems with what we're now talking about as digital health equity. So I think that, you know, this early postpartum group, clearly a group that is having more frequent visits and is able to access it. But I am worried about this lower income quintile group because it doesn't make sense that they would not have more need for care in this context. And then finally, I thought it was interesting to show you some of our mapping in terms of the rates by regions. And in March, everything, the darker it gets, the greater difference between the observed versus the expected rates that we're seeing. And what you can see is in March, it's still reasonably light. In April, quite dark. May maybe a little bit better, but June quite dark. And so there is variability across the province, and we know that there is variability in access across the province. And so I think it's important to think about, you know, are these rates different because there were different case rates, people were less anxious, there were different types of restrictions in different regions, or actually because not all regions had the ability to, not all people in all regions had the ability to access care. So in summary, what I would say is that we did see higher visit rates for postpartum mental illness during the first 4 months of the pandemic than we would have expected based on prior use patterns. And that for this population, at least, the data on anxiety, depression, and alcohol and substance use are consistent both with the hypotheses about the potential impact of COVID and with survey data. But I think these do represent the first data to confirm this increased burden. Early postpartum is a key time of need, and I am worried about whether women in the lower income neighborhoods are able to access care. So what does this mean? Obviously, we need to know how this is playing out over the longer term. But even based on what we've seen, I would say that we do, even for those children from the early pandemic, we should be watching the health development of the kids and the mental health of mothers over the longer term. And, you know, with this massive transition to virtual care, while there is some evidence around efficacy of virtual interventions, we do need to know more about who is able to access these virtual interventions, who are the interventions virtually good for, and who are they not good for. And I think there's quite a bit more room in the mental health space to be thinking about that. So thank you. I will sign off. I don't know if we have time for questions now, or maybe leave it to later.
Yes, Simone, it's Paul here. There is a question in the chat about wanting to know a little bit more about how you modeled your expected visit. So I think it's like figuring out how you do the observed minus expected. It's probably worthwhile taking that question now versus later.
Sure. So what we did was we used a negative binomial regression model, taking into account the 4 years of data and taking into account all of those data points in order to create a model that would generate the expected for each month. And when you do that, you have to account also for that seasonality. So it ends up being similar to a time series model, but it's not, because once we have more data, we will probably do a time series model, but we wanted to look at each of those months separately and not necessarily to lose anything in the trends. And then comparing the observed to expected, we just used a Z test to get the rate differences, but it was a negative binomial model and accounting for seasonality. But I do have a slide that thought it wouldn't be for today, but I'm happy offline to discuss the modeling with anyone.
Great, thank you very much, Simone. So I think from here, we've gone from very high level indicators that I presented to tracking what's happened from this shift from in-person to virtual to a very deep dive into a specific population. Now we're going to shift to the work that was done by Ryan Monte and his team within the Center of Excellence to deviate from the kind of health administrative data that we use routinely at ICES to think about how to stand up responding to the understanding what's happening in other sectors of the healthcare system, and including just basically what can we do to really stand up stand up sort of rapid data availability to help us understand what's happening and to be able to respond from a policy perspective. So thank you, Ryan, for coming, and over to you.
Thanks, Paul. Really appreciate the invitation and the chance to sort of talk about this a little bit. I don't have an acknowledgement slide, which is my mistake. I should have done that. But there's a huge team that that sort of helps contribute data to this and help put all this together. So there are a lot of people involved, and I'm just happy to sort of be able to kind of represent them and talk about some of this work. And so, we put out a report, about once a week, and it goes, pretty widely to the mental health and addiction sector. And, it started in, the spring of, the depths of the first wave of the pandemic, when everyone was sort of scrambling to try and figure out what was happening. And, that was sort of the genesis of this work. And really, the three objectives, they're all a little bit derivative of each other, but, we want to be able to sort of see, have somewhat of a bird's eye view into, what's happening in the system, be able to sort of flag and, emerging issues as they sort of pop up. And ultimately, we hope that all of this work, helps people make decisions based on, what's happening versus what people think is happening. And so really, that is, one of our biggest sort of goals with this work. So it feeds initially, primarily, was feeding into, and still is, into the mental health and addictions COVID-19 response table. And so this table was convened again in the depths of the first wave last spring, to deal with the fallout and the impact of the pandemic on the mental health and addiction sector. And the hope is that this group would make evidence and data informed recommendations both to Ontario Health, leadership at Ontario Health, and the government. And that's really one of the sort of primary audiences of this work. And so early on, similarly to what was happening in long-term care and retirement homes, we weren't able to sort of have a good view into the transmission of COVID-19 in mental health and addictions congregate care settings. So we looked into using the IFIS database, and it just didn't have the information that we needed. And so similarly to what happened with long-term care retirement homes, we had to sort of construct new data collection to understand the transmission of COVID-19 in congregate care settings and mental health and addictions. And so we started surveying the sector about weekly. And so there really are sort of two sectors. There's the child and youth mental health sector, and then there's the adult sector. And so the adult sector was surveyed through the Connects Ontario database. And so where there's unfortunately nothing that is analogous for the child and youth sector. And so while we had the Connects Ontario database, and we were able to sort of insert questions in there to let health service providers notify us and when they did have COVID transmission or confirmed cases in their settings, or even suspected cases in their settings, there was no such system for child and youth mental health that we could easily sort of use. And so we had to start surveying the sector weekly. And so, and one of the nice things about this is that it also gave us a chance to sort of feed back information, to those providers. And so, we were able to, get information from them, but, share some of the information back, show them their data back, and also, share resources that would be helpful, dealing with the pandemic. And a lot of this work was, it was, and I think, it was, it's spoken to a little bit early on, you had to sort of, try and, construct data collection to try and understand what was happening, because, and I think one of the presenters mentioned that one of the goals is real-time kind of monitoring, and we just don't really have that, right? And so, and especially for things like virtual virtual services that were sort of kind of put together within the span of a few weeks, and so there were some programs that we created to help healthcare workers dealing with the stress and the mental health effects of the pandemic, and as well as the general population. And so this part of the dashboard, and you'll see the whole dashboard in a second, just kind of shows some of the some of the uptake of some of these services that we were providing, or that we sort of that we created to deal with the pandemic. And you can see that we saw some pretty large uptake in Bounce Back, and which is a free skill building program for that's targeted to all Ontarians age 15 and over. So we saw about 7,000 sort of individuals sort of enroll in that program, and we saw tremendous uptake in ICBT, internet-based cognitive behavioral therapy. Well over 20,000 individuals have enrolled in that program, and of that about 1,222 are healthcare providers as well. And so we created new data systems to sort of track this and do some load leveling to understand who was actually accessing the services, where we needed to target them a little bit better, who we needed to target them a little bit better too. And that really has sort of been a bit of the sort of story of the pandemic. It's just creating data collection and systems to try and sort of as rapidly as possible try and figure out what's happening. And so this is the there's a whole report that goes out. It's about 20-25 slides or something like that, and it's in the form of a PowerPoint deck. But this is the main sort of dashboard that we created in partnership with the ministry, to try and get a good bird's eye view into what's happening, and this is sort of the key dashboard that we that is informing decision making, both at the COVID-19 response table. Minister Tobolo, I believe, takes this with him into cabinet meetings as well, and so this is sort of the main dashboard piece of information that gets used to inform decision making. And there are a few different sort of modules in here, and so early on everyone was really and that was really kind of where this sort of started, right? There was a real fear that community mental health and addiction services were closed. They were just closed for business early on, and we did see a substantial sort of closure of services very early on, last March, April, with the initial shock of the pandemic. Everything really closed down, across sectors, and we did see that sort of spill over into the mental health and addiction sector. But once people got set up for virtual, figured out the IPAC situation, we saw them sort of, rapidly open up, with modified services. And now, we've seen this, resilience, through the second wave, and, if there's a third wave, I think we will see that resilience continue, where we'll see the majority of programs open and provide services to their clients. And so the first module over here, continuity services, you can see that where both adult and child and youth programs have stayed open. And we do see a little bit of in certain regions where staff absences continue to be an issue, and there are some gendered effects over here. We know that childcare has been a real issue, and it's kept women within the from participating in the labor force to the extent that they were prior to the pandemic, and so there's some of that happening over here. There are definitely some resource constraints in terms of there's a just like a lack of resources and human resources in certain areas that can be pulled into these jobs. And so there are certain areas where staffing does sort of remain an issue. We've seen that sort of continue a little bit more so in the adult sector than the child and youth. And we just sort of walked through the the digital and virtual services module over here. We also have system monitoring, where it's very high level, and Paul and others have talked about this already. What we've been seeing with ED visits, and there was again, like the initial sort of shock where visits dropped and has somewhat recovered. Connex Ontario contact. So that's one of the best sort of views into sort of real time. We get this updated every day, and so this is one of the best sort of views into what is sort of the real time sort of need. And so it's just folks calling into Connex Ontario and looking for referral to services, mental health and addiction services in their area. And so this is just the number of people that in a week are making contact with Connex Ontario looking for service. And so we continue to track this as it's gives us a little bit of a barometer as to what is that real time need. And I mentioned earlier, we have surveys that we conduct weekly to to understand the transmission of COVID-19 in congregate mental health and addiction settings, and that's some of that data is displayed over here. And so you can see the number of active. So this is as of last week, the number of active COVID-19 cases in the adult sector, the child and youth sector, along with the cumulative cases. And the number of sites, the individual sites with active cases, and unfortunately also, we see the number of deaths over here, and hopefully that stays, pretty low. And finally, one of the most important pieces of information that we show on this dashboard is, one of the most, I think, devastating fallouts of the pandemic is, the large increase in opioid-related mortality and drug, and just, more broadly, the drug mortality. And so, you can see that, in the most recent month for which we have data, it's December 2020, and we work pretty closely with the coroner's office to get this information and keep it, pretty up to date. We saw 344 suspected drug-related deaths. That's the greatest number in a single month that we've ever seen in Ontario. There's reason to believe that based on what we're seeing locally in Toronto and in the city of Toronto, that this is, this number is not going to, get better in January or February. And so, it's something that we continue to pay pretty close attention to. And so one of the slides that we, again, that we kind of show in our weekly reporting is, is the slide over here. And so, this is just like, a bit of a longer view with a little bit more information on how mortality has changed in 2020 compared to 2018 and 2019. In 2019, there was some hope across the country, really, that that we'd seen a bit of a leveling in drug and opioid related mortality, and then that's just skyrocketed in 2020. And this is something we're sort of actively kind of tracking and monitoring, and and feeding information to decision makers. And so just some key messages. Checking time right now. So the majority of mental health and addictions community services have remained open in some form. Many of them have moved over to virtual services or providing, modified services. And staffing does remain an issue in some regions. The pandemic has, worsened the toxic drug crisis, and we've seen that, across the country. And like I said, December 2020 was, the worst month in our history for drug-related deaths. And like you saw in the presentations earlier, we've seen a steady uptake of virtual services. It really has been like a massive sort of transformation Some have said like, it's 10 years worth of growth in a single year. So, something that we've seen and we think is going to, really continue. So that's it. I can take questions if there are any questions, if there was anything that wasn't entirely clear.
Thanks so much, Ryan. There is a question, but before I just wanted to say that that's the end of our content. And there are a number of sort of meta messages that we want you to take away. One is that there actually is quite a bit of measurement that we are capable of within the mental health sector. It is a little bit more piecemeal than we would like, but what you can see is that the ICS team has developed quite a bit of expertise in measuring what's happening with the data that we have. And also what you can see is the ways in which measurement capacity was stood up very, very quickly by Ryan and the team within the Mental Health and Addiction Center of Excellence. And what we are hoping to see over time is what is currently a very nice emerging alignment between the measurement capacity of the two teams to really work in concert to be able to answer some questions. And my colleague Danielle Martin is on in the audience as well. We're also thinking within the Center of Excellence very carefully about what a data and digital initiative would look like for the province to allow us to have a much more comprehensive picture than we had going into this pandemic. So I think that we are able to know more than we thought, but we're also thinking very critically about what we need to know going forward and the structures and processes we need to put in place. So we can take more general questions, but Ryan, there is a question about the opioid related deaths, and it is asking you whether those deaths that you captured reflect only deaths in the community, or do they also capture deaths that may have occurred in hospitals?
So we get this data from the coroner's office, this vital statistics, and so this captures everything in the province. Every death that occurs, there is an investigation that's done by the regional coroners, and that information then eventually gets fed into the coroner's office, and so this does capture everything that happens in the province.
Any other questions for Ryan or for anybody else for that matter? A question for Simone, and that is that can you tell us in a little bit more detail the kind of services that may occur in the postpartum period pre-pandemic and how that has shifted, and then sort of think about what you're observing as in relation to that?
Sure. Services, Paul, in terms of the public health kind of services or the mental health services?
I would say both. Like just like what pre-pandemic, what was the normal way that new mothers access services? How were they?
That's a great question. So the public health program, Healthy Babies, Healthy Children, is a comprehensive provincial-wide program that provides support to pregnant women and new mothers. The nursing support can include screening people for postpartum mental health issues, setting up peer support groups, so parent-to-parent support groups, as well as nurse-led support groups. They were doing a little bit online, but a lot in person prior to the pandemic. And both peer support and nurse-led support groups are evidence-based treatments for mild symptomatology of postpartum depression and anxiety. And when people have more than mild symptomatology, that's where we'd be getting referrals into the medical system. First in primary care, and where there are, let's say, family health teams, for example, there might be social workers, psychotherapists who are part of the teams who can help with psychological treatment, because we probably wouldn't even be thinking about medications when someone still has mild to moderate symptoms. But once someone has symptoms that are really starting to affect their life, their relationship with their baby, increasing distress, that's when we're starting to think about referrals to specialized, medication, which can be managed often in primary care, as well as referrals to specialty areas. At Women's College Hospital, we have had since 2016, we've had an online therapist facilitated postpartum mental health support group. And even prior to the pandemic, we had done some trials using virtual care for psychiatric care in our pregnancy postpartum mental health care program, as well as psychotherapy. And so, I think what has happened with the shift of the pandemic to virtual is that a lot more is happening virtually. Luckily, because we had some of these data already, we knew a little bit about what worked and what didn't work about virtual care. And, I think the big issue right now, as I can tell you, in our clinical programs, our referral numbers have close to doubled. And so now, so what you see in the provincial data, I can tell you is happening on the ground in our clinical specialty programs. And so actually next week or the week after, we are launching an online web-based forum where we have a care coordinator. Women can self-refer online, and a care coordinator who will talk with women with high levels of symptoms, set them up with the resources that we have that are pregnancy and postpartum specific, as well as try and triage them to some of the provincial virtual programs, to our online support group, as well as working with the primary care physicians and then referring to specialty care as needed. And I think those are the kinds of interventions we need. We really need to match people's need to care. And I think we can leverage technology to do so. So, people will hear more about that, and that will be open to all women provincially, because I think it's just so clear how much this population is struggling.
So there was a bit of a stepped care system in place that may have been disrupted a little bit, and now you're trying to course correct by creating that first step virtually.
Yeah, and I think doing it in a more, trying to make it more efficient, because it's become very clear that there's more demand.
Yeah, thank you. There's a question in the chat about the overdose deaths. Is there a sense of how much increases in street drug toxicity is contributing versus an increase in rate of use of these drugs? I can take this not because I'm an expert on this, but because I had a recent chat with Tara Gomes, who is the ICES resident expert on this. And she's been monitoring this very closely. And I would say my takeaway from my conversation with Tara is that there definitely is an increased lethality. And in fact, there are synthetic benzodiazepines being added to the fentanyl that's coming in. And this is problematic in two ways. One is that it increases the lethality of an overdose, because the benzodiazepine is an added sedative, which exacerbates the decrease, the depression and respiratory drive that you experience during an overdose. It also is problematic because if people go for treatment, for example, on methadone or Suboxone or buprenorphine, if they are using large quantities of fentanyl that's laced with this benzodiazepine, they can experience the benzodiazepine withdrawal, which would not be covered by the methadone or buprenorphine, which would increase their likelihood of relapsing. So they might be confused about the fact that they're experiencing withdrawal symptoms that are not covered by the buprenorphine or methadone. And that's precisely because the withdrawal is not from the opioid, it's from the benzodiazepine that they may be unwittingly injecting or consuming. The final piece that Tara is really concerned about is that there is an increase in use in isolation. And so now naloxone kits don't work when you're on your own. So those are the biggest factors. There are other factors that she talked about. So it's not clear, the last piece about there's increasing rates of use, but there's pretty clear evidence of increased lethality and the socially distanced measures that the public health needs to impose on everybody may be having an unintended consequence of increasing the overdose deaths because people are not being observed by their companions while they use, and there's missed opportunities to administer naloxone and get help. It's a great question, it's an area where, from my perspective, we are able, like you can see Ryan's work in concert with the coroner, we can keep very close tabs on in near real time about what's happening in terms of deaths. It's just we need to really stand up a concerted effort to intervene, and my sense of things is that the individuals who might intervene are kind of distributed across different jurisdictions. By jurisdictions, I mean there's a public health component to this, there's a treatment component to this, and I think there's probably an opportunity to better coordinate and get people around the table to figure out who does what. But we're definitely in a situation where we can monitor progress over time to hopefully reverse what I consider a fairly horrific trajectory, to be honest, as this has gone on. Are there any other questions? I guess for Alene and Natasha, I wanted to know, Alene and Natasha are both pediatricians of sick kids. You know, we have the benefit of being clinician scientists. Is anything you observed surprising to you from what you are doing clinically, or did it kind of resonate?
So for my clinical practice, which I see a lot of children with mental health conditions, for me, it did, because what I found is that, what we were seeing in media reports about mental health was not what I was seeing in clinic, in that some children, so for example, the 12-year-old girl with social anxiety now doesn't have to attend school, never has to be triggered by some of the bullying or the stressors that she's facing at school, and is actually doing better from a social anxiety standpoint. Or, the 8-year-old boy with attention deficit hyperactivity disorder who now has a parent sitting, 6 feet away from them, refocusing them on the computer work, is actually doing better and is able to attend to their schoolwork, is actually doing better. So from that standpoint, it's not surprising, because for some mental health conditions, kids are actually doing better. I think Dr. Toulany might be able to speak to some of what's going on in the eating disorder world, which has seen sort of the opposite effect. So, Alene, I don't know if you want.
Yeah, so in contrast to some of the kids that are experiencing improved symptoms related to their anxiety, we are seeing disease groupings, including young people with eating disorders, that are experiencing more distress. So anecdotally, we're admitting a lot more children from the emergency department with severe eating disorders. And what we've noticed clinically is the rapidity of the weight loss and the severity of weight loss is different than what we were seeing before the pandemic. And similarly, on the other end of the spectrum, young people with obesity and overeating disorders are experiencing the opposite problem. So I think the story is complex, and we need to look, at the nuances and by disease groupings to really understand the story for each of our different populations.
Yeah,
I had a conversation with. Oh, sorry, Natasha, did you want to say something?
The other group that I think it'll be interesting to see how it plays out down the road is delays in diagnosis for young children with neurodevelopmental disorders. So many of my patients, or patients that I've seen through the hospital, have not been able to get their assessments, for example, for autism. And then that, a 6-month delay in diagnosis then leads to 6-month delay in treatment and funding for treatment. So it'll be interesting to see how that all plays out, because many of those community-based services were actually put on hold somewhat indefinitely in the first several months of the pandemic. So that's another group that I think we have to keep an eye on.
And for both of you, did you want to, there's a question about, the Statistics Canada survey data on that suggested that, the percentage of kids saying their mental health was the same or even better. Did you want to do you want to comment on that in light of both your clinical experience and some of the data that you've been working on?
Yeah, so I mean, I saw the Statistics Canada report, and I think that, survey data is very different than utilization data. And it's a voluntary sample of adolescents or children who were willing to answer it. And so I think if you got a population level non-voluntary sample, you may find different results. But it is true that some kids actually, I mean, with respect to the utilization, some kids are actually doing better. They are spending more time as a family. They may be feeling more supported and less lonely. For the 13-year-old in distress who feels ignored by her parents normally, maybe now she actually, is getting a lot of attention from her family. And so it's not surprising that some are doing better and some are doing worse. And so on average, we're seeing the numbers flat. I don't know, Alene, if you have thoughts on that.
Yeah, I mean, I agree with Dr. Saunders. I think the population is really important to understand who was sampled, how they were sampled, and what were the questions they were being asked, and how that's being interpreted. I also think it's important to look at the timing of when the survey questionnaire was distributed. Kids and young people, like adolescents, thrive on routine. So if you're doing it in September and October when they're back to school and in a bit of a more structured environment, perhaps some of the symptomatology is improved.
I was just going to add, related to the eating disorders, we had a meeting yesterday with the Center of Excellence, and Dr. Randy McCabe is a psychologist at St. Joe's in Hamilton, and who does some work in this area, clinical work in this area, and what she has been observing anecdotally is that kids who are inclined to have eating disorders are actually, because they're at home, they're able to exercise much more frequently, which is really complicating the presentation. We are at 10:57. I want to thank all the presenters, and I hope what you take away, and I want to thank everybody for listening and attending our session. I hope what you can see is that we are a team, and that we're a small subset of this collective team that's very invested in doing what we can to shed light on what's happening, and we will continue to work and we'll continue to push the envelope. But I would say the summary statement is it's hard. It is hard to get a read on the mental health consequences of the pandemic. It's complex. I think that it's safe to say that there's quite a bit of resilience within the public. I think it's also safe to say that there are factors that would make people particularly vulnerable to new mental illness and addiction during the pandemic. And I think there are circumstances with the shift to virtual, and we'll be doing, and especially Alene and Natasha will be doing more detailed work on this. I think the story about the winners and losers of the shift to virtual will emerge, and I am guessing that it will be an equity and complexity story, that the individuals, and you started to see that with the income gradients, right, and the shift to virtual. So I think that this story will emerge, and we hope to do it in a timely fashion to be able to course correct and use the information. So thanks again for all the presenters. Thank you very much for attending, and stay tuned for more work. There's a lot that we're doing as we pivot to the pandemic, and we will be doing our best and our fastest work to get this evidence out there.